Assalamu alaikum everyone. I am Dr. Adan Zahoor, Chief Organizing Officer at Experience Dentistry. I am delighted to host our third session on of dental radiography. Our guest speaker is Dr. Noor Sana. She is compassionate and community-driven dentist making oral health care accessible to all. A graduate of Jinnah Medical and Dental College, she completed her house job at GPMC and then internship at Dove University and JPMC in oral maxillofacial surgery department, gaining hands-on experience in the oral and maxillofacial surgery department. Her journey in clinical dentistry began at FMJ Healthcare, where she joined as an internee and was promoted to lead dentistry by October 2024, a testament to her dedication and clinical skills. Dr. Sana has actively organized numerous dental camps, especially focused on children with special needs, patients from welfare organizations, and elderly residents in old age homes. Her vision goes beyond the clinic as she compassionately engages in preventive dentistry, community outreach, and awareness initiative. Currently, she is impactfully sessions on dangers of vaping, shisha, and among teenagers, highlighting her commitment to youth education and public health. Please welcome Dr. Noor Sana. Assalamu alaikum, Dr. Noor.
Walaikum assalam, assalamu alaikum everyone. So I'm Dr. Noor Sana. Doctor, then give my intro. So we will look forward to our presentation. In today's presentation, I will explain how to understand dental radiographs, what is normal anatomy, and what sign indicate disease. Because accurate radiographic interpretation is the cornerstone of effective dental radiograph. Sorry, accurate radiographic interpretation is the cornerstone of effective dental diagnosis and treatment planning. So, if you have not a clear understanding of what's normal and what's abnormal on a radiograph, we risk misdiagnosis, any mispathology, or even we do sometimes over treatment. So, simply put, if we cannot interpret the image correctly, we cannot plan the right course of action for our patient. So, moving forward to our first slide, in this slide we will cover common types of dental radiographs and indication. So basically we have two types of radiographs. We are majorly subdivided intraoral and extraoral. In intraoral we have periapical, bite wing and occlusal, and in extraoral we have OPG and CBCT. So moving to next slide. Here is a picture of different types of radiograph. The A is bite wing, B, B is showing occlusal, C is periapical, and D is OPG, right? So when we have to do these X-rays on which conditions, so bite wing is when we have to look about upper and lower crowns for caries and any bone level indications or any interproximal caries. In occlusal, we have a wider view of jaw. We have to see full arch, and mostly we have to do this radiograph for the infected teeth or fractures. In periapical, which is mostly used in clinics, this is give a view from full tooth from crown to root for infections and bone loss. OPG give a whole jaw view, good for fractures and third molars. So the next slide is cone beam computed tomography, which is basically the CBCT, and it's a specialized type of 3D imaging used in dentistry for detailed visualization of jawbone, teeth roots, sinuses, pathologies and implant planning. Basically, the CBCT is mostly used if mostly for implant planning and sinuses because it's a 3D and it's gives a very good view and about the bone evaluation, checking sinus and nerves, detecting cysts or tumors, implant planning because it has more detail than 2D X-rays. So moving to next slide, where we have to learn about the radiographic anatomy of a normal tooth. So this is a periapical radiograph, which shows from tooth from crown to roots. Okay, so the basic structures of a normal tooth on X-ray. So this is labeling of enamel. Enamel shows in X-ray the brightest white layer. Then we have dentine, less bright under enamel, pulp chamber, dark center with nerves. Then we have CJ, cemento enamel junction, link where enamel meets cementum. Okay. Then we have pedial space. If you look, uh, so pedial space is the thin black line around root. Then we have alveolar bone, like a trabecular pattern, and root apex. So root apex, mostly if we have any periapical infection, so this is a very important landmark, the root apex. So when we have any radiograph, so we have the full view of radiograph, so we saw the full crown and the root and its apex, so we don't miss any pathology. Now, so this is the periapical radiograph. Moving forward to look the normal OPG view and key anatomical landmarks of normal OPG. So this is the labeling. Okay. So the first one is middle cranial fossa. If you look the above one, okay. The two is orbit. Three is zygomatic arch. Upper the your maxillary teeth. Four is palate. Five is styloid process near to TMJ below, and six is maxillary tuberosity. Seven is external oblique ridge. Eight is angle of mandible. Nine is hyoid bone. 10 is glenoid fossa. 11 is articular eminence. 12 mandibular condyle. 13 vertebra. 14 coronoid process. 15 pterygoid plates. 16 maxillary sinus. 17 earlobe. 18 mandibular canal, and 19 mental foramen. So basically, if we look into the maxillary sinus, so it's dark area above the molars, and it's a sinus floored like a white border. Moving to next slide, in which we saw the each radiograph with a anatomical landmark. Maxillary radiographic landmarks, which is more important: maxillary sinus and sinus floor, nasal septum and interior nasal spine, zygomatic process and arch, incisive foramen and canal, and inverted Y. So in the next slide, we have radiographic presentation of these landmarks. So in first picture, this is a median palatine suture, and the next picture, this is the nasal septum. Sometimes we miss this, if this is any pathology or any perforation or anything. So no, this is the nasal septum. Midline white structure. Okay, the spine and having midline white structure. Inverted Y, this is the median palatine suture, nasal and sinus intersection. On the next slide, we have nasal septum and floor of nasal fossa. So in the nasal septum, This is a midline white structure, and this is a floor of nasal fossa. Come to the next slide. This is the intermaxillary suture. Sometimes we miss it like this is any uh, radiolucency or any periapical lesion. So this is the intermaxillary suture. This is the zygomatic process, shadow of zygomatic arch. Next, move forward to mandibular radiographic landmarks. In mandibular radiographic landmarks, we have important some structures like mental foramen, mandibular canal and border, lingual foramen, genial tubercle, mylohyoid, and internal oblique ridge. So this is the OPG view of, and we have some important landmarks there. Nasal septum, anterior nasal spine, which we saw differently in the above radiographs also. And zygomatic process, submandibular fossa, genial tubercle and lingual foramen, internal oblique ridge running along the third molar, and we have mandibular canals. Seeing some normal radiographic pictures of more mandibular structures. So one is condyle, two is neck, three is sigmoid notch, four is coronoid process, five is ramus, six is inferior dental canal, seven angle, eight body, nine mental foramen. This is not any periapical lesion. This is the mental foramen. Okay. 10 is symphysis mentis, and 11 is an external oblique ridge. We have next radiograph. Here we see the what is inside or posterior to third molar. So we have humeral notch. It is found between humeral process and maxillary tuberosity. We have hamular notch and a maxillary tuberosity. Next slide is about incisive foramen. It is opening in the midline of the palate just posterior to the central incisors. It gives passage to the nasopalatine artery and nerve. So it should not be misdiagnosed as dental infection or cyst because this is the area of incisive foramen just posterior to the central incisor. Next we have cervical burnout. So cervical burnout, it's a basically not any pathology or anything. It's any sometime we took the X-ray and we have some uh, angle. We have some angle distribution and anything. So that come with an X-ray have cervical burnout. So radiolucence band running across the tooth in area not covered by enamel or alveolar bone, especially the neck of the tooth, because it absorbs less X-ray than areas below and above. So if you see the radiograph, this is the neck of the tooth, this is the cervical burnout. And we often misinterpret this the any root caries or cemento enamel caries, but this is the cervical burnout. We have the difference in the next slide, so you can differentiate what is cervical burnout and how to differentiate from the caries. So these are the slides in which we see the normal landmarks, because for detecting pathologies in dental radiograph, we have the good command on our normal radiograph. We have to know the normal landmarks so we can identify the pathologies. So moving to the slide. This is the sorry. So let's begin with radiographic sign of dental caries. So these are the silent zones which caries hide. So what we are seeing here, this sequence show case 1 to case 5, highlighting the progression of interproximal caries. Case 1 to 2, it's just an early sign of just enamel involvement. Case 3 to 5, lesion penetrating to dentine. A radiolucent notch just below the contact point. So this is our first clue when we are seeing the radiograph. So when we read radiograph, always show down at the interproximal contacts. This is where the earliest caries start basically. Not as big shadow because interproximal, the caries start initially from the interproximal or occlusal side first. So extremely small notching in the enamel surface below the contact point, the case 1 and case 2. I am talking about the case 1 and case 2. This is also called incipient caries. Often we can miss this. So next slide we have occlusal caries. So occlusal caries, this is basically the early stage. And if we say occlusal caries hide like in the valleys, the pits and fissures, in early stages they can be deceptive, but clinically you might see a discolored feature when you see in the patient mouth, and patient sometimes give a history of okay, when we are eating any cold and it has pain or sharp like, and then it's disappear even in a second. So this is some sign you can detect or you can see clinically the pit and fissures discolored. So this is the early stage. So they begin clinically visible before radiographically detectable. So within radiograph, your clinical history and your clinical examination is very necessary. Without these three, you can't plan a good treatment plan. So this is the occlusal caries. Then we have bags. So in the occlusal caries, it's in pit and fissures of the posterior teeth. In early stages, they may not be visible radiographically unless the lesion extends. Then we have incipient caries, which we see saw in our last slide. That incipient caries, it's a notch-like. They are the earliest visible sign of enamel demineralization, appearing as a faint radiolucent triangle just beneath the contact point. Okay, next slide. So this is the picture of cemental root surface caries. As you are seeing the premolar region, it's an expose the root surfaces, especially with gingival recession. They appear as ill-defined radiolucent areas near the CEJ. So don't confuse cemental caries with cervical burnout because as we learned that cervical burnout is around the neck of the tooth where our X-ray beams or light come low. So this is come with the cervical burnout. But this always make sure that when we have cemento enamel or root caries, so we have gingival recession there, which also appear as a reducent band near the cemento-enamel junction, but has a more uniform, fuzzy, and symmetrical appearance on both sides. So cemental caries are irregular and often asymmetrical, but cervical burnout has symmetrical appearance. So these are the difference between both. So moving forward to periapical lesions. So periapical lesion appear as radiolucent area around the apex of non-vital tooth. They indicate chronic inflammation due to pulp necrosis. Common types include periapical abscess, granuloma, and radicular cyst, differentiated by size, borders, and symptoms. So this is the periapical radiograph view. and this is the molar, and you see at the root apex the periapical lesion. Any patient having periapical lesion on the tooth, they come with swelling and the pain. So basically, how to differentiate between abscess, granuloma, and radicular cyst? So first thing, always correlate radiographic findings with clinical tests like percussion and pulpatility, and the history is main important. So moving to next slide, where we see the difference between granuloma, abscess, and periapical cyst. So this is the periapical abscess, the periapical radiograph, which is diffuse, purely defined radiolucency with possible widening of PDL space. So this is an abscess case. If we see the periapical granuloma, this is the well-defined but non-corticated radiolucency. If we see periapical cyst is well-defined corticated radiolucency, typically it is than 1 centimeter in size. So now we have some differences. Like this is the most important structure in the premolar area is mental foramen. So if we see the first radiograph, below the premolar we have mental foramen, and sometime and on the next below picture we have premolar, but this is not a mental foramen. So don't miss any periapical lesion with the mental foramen. Mental foramen is not associated more closely with the apex, and the periapical lesion is more closely associated with the apex and the widening of the PDL space. So the best way to differentiate periapical disease from the mental foramen is to identify the periodontal membrane space to see if it is confluent with the radiolucent opening. Next slide is about tooth fracture. So sometime having any trauma or incident, especially with the children, and it's come with the radiograph, and you have to see very clearly that the fracture line and discontinuity in the outline of the tooth are the most usually observed sign of fracture. So it must be remembered that it can have an appearance that stimulates a fracture, and fracture segment can be superimposed in a manner that hides the fracture multiple view of the questionable area ordinarily resolves such difficulties. So if we took the periapical view of radiograph seeing the tooth fracture, then you can, if have any history of trauma, you can so about the fracture lines or any maxillary tuberosity fracture or anything, you can took X-ray of OPG also to have a broader view of this. Then on the next slide, we are talking about root end changes, like most important hypercementosis, which is clubbing of root, radioopacity related to the root surface. If you see in the radiograph, the bulbous and hypercementosis area in the, it's not a normal. If you look, if you have a good knowledge of a normal X-ray, then you can easily differentiate between the hypercementosis and the normal roots. So in the next slide, we have root resorption. So in the previous slides, you can see about the periapical lesion, which is also associated with root apex. So this is root resorption. If you have a good command how periapical lesion see and how it's looks, so you have easily differentiate between root resorption, hypercementosis, and periapical lesion. Root resorption is basically it's resorb your roots. They look at both the X-rays. You can't see the apex clearly. So a smooth root resorption, smooth root periphery, rough root resorption, roughened root periphery. The first one is smooth root resorption, and the second one is rough root resorption. Then in the next slide, we have enamel pearl and pulp stone. This is two different X-rays, and you look both are looking different. Acha, if we are look about the enamel pearl, an enamel pearl is a small, round, radiopaque mass of ectopic enamel, usually found near the furcation area or along root surfaces. It may contribute to periodontal issues if it interferes with attachment. So don't confuse with pulp stones. Enamel pearls are a part of the tooth structure and are often seen in molars near root bifurcation. So mostly enamel pearls you are seeing in the molar area near the root bifurcation. It's not inside the tooth or inside the pulp, because if you see the pulp stone, it is inside the pulp. Okay. So a pulp stone appear as a small, round or oval radiopaque mass within the pulp chamber. As you see the premolar area, you can see the pulp stone below the cemento enamel junction inside the tooth in the pulp area. So it is in the pulp chamber or canal. It is usually asymptomatic and an incidental finding when you have, sometime it is very clearly in the radiograph, but when you can do root canal and opening the chamber and do filing, you can easily detect it. So don't confuse it with foreign objects or internal resorption. Pulp stone have well-defined borders and do not alter canal outline. So these are two different things. Enamel pearl is outside the tooth near the bifurcation, and pulp stone it is inside the pulp chamber. Then we have the supernumerary teeth view in an radiographic form. So these are supernumerary teeth. Basically, these are the extra teeth beyond the normal dental formula. They may appear anywhere in the arch and are most common in the anterior maxilla. Mesodense seen as well-defined radiopaque structure resembling a small teeth. If you look the radiograph, these are incisor view, and you have see the small teeth-like structure between the two incisors. So these are some we have common pathologies or common views of our radiograph, which is seen in our normal clinical uh, routine. So moving to slide, these are the two pictures. This is the first A picture. If you can see or diagnose, anyone in the comment. So the A picture is basically, this is the radiograph periapical view, and the patient come with the complaint of having swelling in the uh, lingual side on both sides. Patient don't have any complaint of itching and pain, but he has like fear, what is this inside and this swelling inside. When we check and taking the radiograph, there is no periapical lesion inside the incisor to premolar region on both sides, but and when we see it, it's an like heart type swelling. So this is basically the lingual canal, and it's if the patient come with this presentation, and you can see in the X-ray, and patient give the history of no symptom, like it's asymptomatic and no symptom of itching and the pain. So basically, we have to let this and counsel the patient that if it's uh, counsel the patient that if it's have any itching on the pen, then the patient should consult with the doctor, and then we have to remove that lingual canal. But if it's present there, there no need to any surgery or anything, because this is asymptomatic and don't give any harm to your oral cavity. The next slide is about the periapical view of radiograph having uh, prosthesis. So this is our, we have the one slide back. So this is the second picture is about this. This is the molar. Okay, patient have prosthesis on this. So what the wrong in this picture, that the bridge part is not have good marginal contact, so the all food infection is here, and it gives periapical lesion to the RCT treated tooth. And the this RCT treated tooth, basically we don't have the full radiograph. Again, if you see the next to it, there is also the molar, and this bridging give wrong to the next one, the next molar. It also this is basically the cemento enamel caries. We don't have the full view of this radiograph, but it's also have. So this the next one, the tooth is which is beside this. This is the cemento enamel caries and the root caries lesion. Moving to next slide. This is our the first radiographic. This is the periapical view, and it is the 6-year child periapical view of radiograph. And if you see the incisor, this one is permanent, and you see the shadow of this cubic, like this is the primary tooth, the milky tooth. And patient don't shade this tooth, and it's coming. The permanent one is coming a little bit lingually. So this is not any pathology. So for this clinical examination is very necessary. So if you look into the patient mouth, you see the milky tooth is retained and the permanent is also arise. The next radiograph is also about periapical lesion at the root apex, and it's smaller. The next slide is about common radiographic artifacts and interpretation pitfalls. So cervical burnout, as we learned about cervical burnout previously, that it's a radiolucent band at cemento enamel junction, often confused with caries. Then we have overlapping contact sometimes due to improper angulation, or then sometimes we see in the X-ray elongation of pore cycling, distorted tooth size. In OPG, mostly if the result is not good, it's look like a ghost size, like due to any metal jewelry or improper positioning. Then we have motion blur, patient movement during exposure, and if we have double exposure using the same film sensor twice mistakenly. So if you took any radiograph and you see there is something missing, so kindly take that X-ray again, so you can have a good diagnosis. So moving toward to next slide. So this is some differences. So this is some differences. This is the proximal surface caries as you look at the above. Okay, like we see in the case one, and this is the cervical burnout at the neck of the tooth. But cemental or root surface caries looking differently, like it's asymmetrical, and the cervical burnout looks symmetrical. So this is the differences, and you can differentiate between the caries and cervical burnout. The second picture is about like it's maybe this radiograph is not good, and you can't diagnose it properly with this radiograph, because maybe this is due to the overlapping contact or due to improper angulation. So this is some pitfalls we have to see in our radiographs. Moving to next slide. So OPG view of radiograph. In this radiograph, patient have complaint of TMJ clicking and the gum tearing, ulcers beside the wisdom, and patient have pain when bites. So if you look this X-ray, you have the upper wisdom with have rotated angulation and the lower wisdom. So in this X-ray now you have to take the correct diagnosis that what to do. If the lower wisdom has no pain and on percussion and no caries, so your next choice is the extraction of upper wisdom, because the upper wisdom is with the rotated angulation. It's kick the bone, and it's making the tearing of gum and making ulcers, and also when it's come to contact with the lower tooth, it may cause pain. So this is basically how you can diagnose it with X-rays. The next slide is about the periapical, and it's so the wisdom is forcing the seventh to second molar, so it gives caries. So when you have a radiograph and any positioning of uh, wisdom there, so it should be extracted wisdom, because that wisdom can cause the pathology or can cause any caries to seventh molar or sixth, second molar or first molar. The third radiograph is about the periapical lesion. This is the molar, and you have seen the black shadow in the crown part. This is basically the patient come with the broken crown. So the broken crown like this, like the crown is break, and you have root having periapical lesions. So the next slide is final takeaways. Radiographic mastery is equal to is clinical excellence. So radiographic support, not replace clinical judgment. Always correlate findings with clinical symptoms, history, and vitality test. If you know that about normal radiographs, so you can spot the abnormal. A strong grasp of normal radiographic anatomy is your best defense against misdiagnosis. Avoid relying on just one view or image. Use multiple angles or advanced imaging like CBCT when needed. Interpretation improves with experience. The more you observe, compare, and review, the sharper your eye becomes. It's a combination of vision, knowledge, and context. Radiographic plus clinical exam is equal to confident and accurate treatment planning. So it's all about how you can take the proper history from the patient, how your clinical examination is like the proper vitality test, the proper percussion, and about the X-ray. If you have these three things, the good command on X-ray, read clinical examination, and the patient history, so you can make the correct diagnosis. And if we have correct diagnosis, so surely you can have good treatment plan for the patient. So it's all about the dental radiographic anatomy, what's normal and what's abnormal. If anyone has any question, please write down in comments.
Thank you so much, Dr. Noor, for the insightful session. Before moving to the question answer session, I would suggest everyone to fill the form, feedback form, and then we will take the question answer session. Dr. Noor, our first question is, what are the common
Hmm.
features observed on radiographs for TMJ fracture?
Acha. So basically, the TMJ fractures on radiograph are basically depending, we say, on the type and location. Because if you have the fracture of condylar head, neck, or subcondylar, so that's type of whether it's unilateral or bilateral. So basically, the features you see is discontinuity or radiolucent line. Like you can see a clear fracture line or a step defect in the condylar head, neck, or in the ramus area, or it's appear as a radiolucent line, or you can see the displacement of the condyle like if you know the normal anatomy of the condyle, how the condyle looks in the OPG view, so you can easily detect the displacement of condyle in the OPG. Like the condylar fragment may be displaced, maybe anteromedially, or maybe superiorly, or maybe posteriorly. And you can look for also asymmetry between the condyle, and also sometimes there may be shortening of the ramus height also in the condylar neck fractures, or you can see a shortened vertical height of the mandibular ramus when you have any fracture. The most important जो हम fracture में देख रहे होते हैं, it's about the condylar fracture. The condylar fracture is, I think, more common. We can see in the clinical practice, and it's all about it can be displaced anteromedially, superiorly, or posteriorly. Or sometimes there is widened joint space also. Like fracture or dislocation can cause the joint space increase, and it's visible in open mouth or transcranial views जो हमारे होते हैं एक्सरे के, you can see easily in there. So these are the like most important features you can see in the radiograph when the patient come with the TMJ fractures. And the scan you can do for this, the first one is OPG. लेकिन if there is not something clear in the OPG, you can do transcranial view or the CBCT scan also, which is the 3D.
Okay, Dr. Noor. Next question is, ma'am, for maxillary expansion after orthodontic treatment, which radiograph is gold standard?
Which kindly please repeat.
मैक्सिलरी एक्सपेंशन के लिए ऑर्थोडोंटिक ट्रीटमेंट के बाद जो है वो रेडियोग्राफ कौन सा जो है ना वो गोल्ड स्टैंडर्ड होगा हमारे लिए?
नॉर्मली जो हमारे पास जो ऑर्थो के केसेस होते हैं, उसमें हमारे पास जो व्यू होता है वो हम सिफेलोमेट्रिक, जो पोस्टीरियो इंटीरियर सिफेलोमेट्रिक रेडियोग्राफ्स होते हैं, उनको हम गोल्ड स्टैंडर्ड समझते हैं फॉर दिस स्केलेटल असेसमेंट. लेकिन
जी.
हम ऑक्लूजल रेडियोग्राफ भी करवाते हैं, विजुअलाइजिंग द मिड पैलेटल सुचर सेपरेशन. बिकॉज अगर आप मैक्सिलरी एक्सपेंशन देख रहे हैं, सो मिड पैलेटल सुचर इज द मेन लैंडमार्क यू कैन सी फॉर दिस. So occlusal radiograph we can do CBCT also because it give you CBCT. So if you can go like you can have 3 to 4 options. Like in posterior anterior cephalogram, you have to see skeletal weight changes on nasal cavity. Like you can saw the 2D view of assessment. Like if you go for the occlusal view, like occlusal radiograph, then you see the mid palatal suture opening, and it's basically we can do for the young patients. And in CBCT, it's like most detailed, but higher radiation dose होती है, so we cannot recommend in every case. We can go to cephalogram or maxillary occlusal view.
Okay. Moving to the next question. During RCTs, how to detect in which canal the file is, especially in mesial canal?
During RCTs, how to detect in which canal
The file is.
Okay.
मतलब कि एक्सरे
So
में हमें कैसे पता चलेगा कि किस कैनाल में जो है वो फाइल है?
बेसिकली अगर आपको नॉर्मल एक्सरे की लैंडमार्क्स और नॉर्मल एक्सरे के बारे में पता है, सो व्हेन यू हैव टू डू आरसीटी यू कैन इजी. मीजल का तब पता चलेगा व्हेन इट्स मीजल इज लाइक विथ प्रीमोलर. अगर वो प्रीमोलर, फॉर एग्जांपल इफ यू आर डूइंग आरसीटी ऑफ मोलर, ठीक है, सो हम कोई पिक्चर यहाँ लगा सकते हैं?
जी लगा सकते हैं.
ओके, आई एम सेंडिंग यू पिक्चर, कैन यू प्लीज. डॉक्टर अदन काइंडली पिक्चर मैंने आपको सेंड कर दिया उसको।
जी जी, मैं बस कर रही हूँ। वेट अ मिनट बस।
ओके।
सॉरी, वो अपलोड नहीं होगी।
एक मिनट एक मिनट। अच्छा आप डॉक्टर अदन, इन दिस स्लाइड वी हैव, हमारे पास स्लाइड है प्री मोलर रीजन वाली स्लाइड, जिसमें हमने मेंटल फोरामेन के बारे में बात की थी। वो वाली स्लाइड आप ओपन कीजिएगा तो उसमें एक एक्सरे व्यू है, सो उसमें हम इस चीज को समझ सकते हैं। नो, नॉट दिस वन। यस यस, दिस वन। नो, द नेक्स्ट वन, प्री मोलर रीजन। यस। सो बेसिकली द आई थिंक जिन्होंने क्वेश्चन किया है वो कंफ्यूज हो रहे हैं कि मीजल कैनाल, बेसिकली मीजोबकल और मीजोलिंगुअल, जब हम आरसीटी करते हैं दो कैनाल्स होती हैं, जिसमें अक्सर कंफ्यूजन हो रही होती है कि मीजोबकल कैनाल में गई है या मीजोलिंगुअल कैनाल में गई है। So the mesial canal is basically the mesial side is the one which is adjacent to premolar. Like if you see this molar, the mesial side is the one which is adjacent to premolar, and the distal side is the one which is adjacent to second molar. So when you have the radiograph in your clinic during RCT, and you can take the radiograph, so you have both two tooth, na, premolar and the molar. So the one is facing towards the premolar is your mesial canal, and the one is facing towards your posterior side, it's your distal canal. Now, sometimes we are confused what is which one is mesolingual and which one is mesiobuccal. So for this you have to take different angles. अगर आप कंफ्यूज हो रहे हो, आप different angles से लो कि कौन सी फाइल गई है, या आप एक 10 नंबर की फाइल ले लो, एक 15 नंबर की ले लो, तो आप उससे डिफरेंशिएट कर सकते हो that which one is mesobuccal and which one is mesolingual. Mesobuccal, मीजो बकल वाली जो फाइल होगी वो थोड़ी बकल के साइड पे होगी, लिंगुअल वाली लिंगुअल की साइड पे होगी। सो जब आप वो फाइल पुट करेंगे और जब आप एक्सरे लेंगे तो आपको फाइल के डायमीटर और लेंथ से भी पता चल जाएगा कि कौन सी वाली 10 नंबर वाली मीजो बकल में गई है या लिंगुअल वाली में 15 की गई है। और आप उसके लिए डिफरेंट एंगल्स भी चेंज कर सकते हैं। लाइक आप उसके लिए स्लोप रूल जो हमारा होता है, सेम लिंगुअल ऑपोजिट बकल, आप मल्टीपल पेरियापाइकल एक्सप्रेस ले सकते हैं विद डिफरेंट एंगल्स लाइक 20 डिग्री, 30 डिग्री, मीजल और डिस्टली ले सकते हैं शिफ्टिंग पोजीशन करके, सो यू कैन इजिली डिटेक्ट कि फाइल आपकी मीजल में गई है या डिस्टल में गई है, राइट? एनी क्वेश्चंस?
No, Dr. Noor, I think we are done. We just got one feedback that Alhamdulillah took all three sessions so good, all of these. We really appreciate your time for those who came and joined in for this session. And lastly, thank you, Dr. Noor, for your valuable insights. It was really an insightful session. I would like to thank all the participants for joining in, and I hope that you guys have filled in the feedback form, as these will mark your presence and will only those who have filled out the feedback form thoroughly will receive an e-certificates. So yeah, thank you so much, Dr. Noor, once again for your time.
Thank you so much. Thank you so much, Experience Dentistry team, for having me on board. And if anyone taking this session or any question, you can contact me and ask any question what you have in your mind again, and go through this presentation. A good and master your knowledge in the normal radiograph first. Then you know easily about what it will be abnormal, and also make sure that clinical history and patient history and clinical examination is very important for any good treatment plan. So yeah, this is all. Thank you so much, all the participants and experienced dentistry team.
Great. So that's a wrap then. Allah Hafiz, everyone. Allah Hafiz, Dr. Noor. Thank
Love
you so much.
you.